It's always dangerous to be the first speaker after a meal because half of the group is asleep already from the carbohydrates that they've just eaten, and people relax. But hopefully I'll be able to give a riveting performance so that you will all listen to me. So my talk is about really the standard of care for patients with esophageal and gastric cancer. Now, my goal is really to explain why it is what we do. There's a reason why we give the current treatments. There is one caveat, though, that I would like to tell you about, and I ask for your understanding. There are patients in the audience and also patients on the webcast. And some people want to know about prognosis and other people don't. So for that reason, we're not talking about survival in absolute terms. I'm going to try to show you why one treatment is better than the other, but we're not going to specifically talk about, this is the life expectancy with this particular treatment. So just so you understand why we're doing what we're doing, okay? So esophagogastric cancer is not very common in the United States. And in fact, only about 17,000 cases of esophageal cancer and 27,000 cases of stomach cancer are diagnosed each year. And esophageal cancer is almost entirely men. You can see this huge disproportionate skewing in favor of men versus women, whereas although gastric cancer occurs more frequently in men, it's more balanced between men and women. Although these cancers are relatively rare in the United States, esophageal and gastric cancer are some of the most important cancers worldwide, particularly in East Asia, in developing countries. These cancers are really secondary only to lung cancer. So they've become quite important and significant problems for the world as a whole. In the United States, as I said, there have been significant declines in stomach cancer. And probably the most important reason for that is that our diet has changed over time. Back in the 1900s, we were eating a diet that was barely refrigerated, foods were salted or smoked, and although that keeps us from dying from bacterial infections, food poisonings, there is still enough bacteria to cause inflammation of the stomach, and that's ultimately what leads to these cancers. With refrigeration and improved food processing, sterilized foods, canned foods, we've really been able to reduce the risk of stomach cancer in the United States. And as you can see from the arrows here, this has been a dramatic decline over time. And our risk for stomach cancer, for instance, is much less so than in other countries that still eat a more traditional diet. The trends in esophageal cancer are also interesting because if we had been standing here in this room 20 years ago, we would be talking about a higher incidence of esophageal squamous cell carcinomas and also distal gastric cancers. But what has happened over the last 20 to 30 years is that there has been a migration of these cancers towards the GE junction. This is the border zone between the esophagus and stomach, so that probably 80% of what we see now is involving the GE junction. The cancers arise in the distal esophagus and extend down into the GE junction or in the proximal stomach involving the GE junction. And this has been a migration that we don't fully understand, although it probably has to do with differences in obesity, smoking, as well as changes in the sterility of our diet. Risk factors for esophageal cancer, you can see this whole table here. This is from an article that I published with Dr. James Mayer, New England Journal of Medicine back in 2003. And if you want a good background, this actually still remains a good article. It's been cited over 3,000 times in the literature. Basically this particular table talks about risk factors, and I'm going to talk about the ones here in red, which really show you that it's tobacco, alcohol, and Barrett's esophagus, which is often related to obesity. As far as tobacco and alcohol are concerned, you can see here that for both esophageal squamous cell carcinoma and esophageal adenocarcinoma, the more you smoke or smoked, the higher your risk is for either one of these cancers. But interestingly enough, alcohol doesn't seem to be a risk for adenocarcinomas. It purely is a risk for squamous cell carcinomas. So the more you drink, the higher your risk of squamous cell carcinoma. And it's been said that more than 90% of all cases of squamous cell carcinoma are related to alcohol and tobacco. Now this is a complicated cartoon, and I just really want to briefly walk you through this. I think the key points that you need to know is that 1 in 7 Americans has reflux symptoms at least once per week, and that 10% of those persons will ultimately develop Barrett's esophagus. And then the question is, will this Barrett's esophagus stay Barrett's esophagus? This is an inflammatory process that changes the lining of the esophagus, or will this proceed to cancer? And you'll see here the statistics of how these cancers progress, and also on the bottom, sort of the general genetic principles in which these cancers, these genetic abnormalities ultimately are thought to change this normal esophageal lining into an abnormal lining and then ultimately into cancer. Risk factors for stomach cancer, you can see the nutritional and environmental and medical causes. Dr. Jurgelin already showed you the genetic risk factors for this cancer, but just to highlight the most important ones, smoking is clearly a modifiable risk, and again, although I suspect that not a single person in this room smokes, again, you may have friends and relatives who are still smoking, and we really need to stop this because it's not just this cancer, it's all the different cancers that are increased by this particular habit. And then H. pylori, which was briefly touched upon, and I think Dr. Jaju will be talking about a little bit more later on. This clearly increases the risk of stomach cancer. This is a bacterium that causes inflammation of the stomach, and people argue exactly what the increased risk is with this bacterium, but ultimately this is also a modifiable risk because we can detect it and we can eradicate it, and that will and it has been shown in studies that doing that can lower your risk of developing this cancer. This is another cartoon that basically shows how a subgroup of gastric cancer called intestinal type gastric cancer evolves from the normal stomach lining to what we call atrophic gastritis, which you basically just need to know is inflammation. And then ultimately proceeds to the cells become ever more abnormal until they finally become cancer. What we know is that H. pylori plays a big role in this, as do certain surgeries, smoking, but on the other side, consuming a diet rich in fruits and vegetables, high in vitamin C, can also retard this process, as can the eradication of H. pylori. So that's sort of a little bit of the background for this cancer. Now let's talk mainly about treatment, which is I think what a lot of people are interested in. And so what are the drugs that we use for esophageal and gastric cancer? Well, here are the chemicals that have been basically developed over the past 3 decades. And again, I don't want you to memorize these structures or even think too much about them, but what you need to know is that a lot of these chemicals are carbon rings that are put together, and because of their shape can basically interact with normal tissues and abnormal tissues in our body and basically gum up the machinery that allows for life to occur, both your own life but also the life of the cancer. Some of the interesting things that I like to talk about is the fact that, for instance, fluorouracil takes a normal molecule called uracil and adds a fluorine atom to it, and basically the addition of that simple fluorine atom creating fluorouracil basically gums up the machinery that we need to develop new DNA and new RNA. Another interesting anecdote or point that I'd make is that oxaliplatin, cisplatin, carboplatin, they all have real platinum in their molecules. So just like the ring that somebody might be wearing on their finger, these agents actually have platinum atoms inside of them. Paclitaxel is interesting because it was originally derived from the bark of the Pacific yew tree. And epirubicin is basically an antibiotic that was changed to make it have anti-cancer properties. So these are the drugs that we typically use, and they can be classified into several categories. The alkylating agents basically keep cells from reproducing by damaging DNA. These drugs work in all phases of the cell cycle. And an example, for instance, is oxaliplatin, which is part of the FOLFOX regimen that I'll show you in a moment. The anthracyclines are anti-tumor antibiotics that interfere with enzymes involved in copying DNA during the cell cycle, and epirubicin is one example of that. The antimetabolites interfere with DNA and RNA growth by substituting for the normal building blocks of RNA and DNA. I just talked about 5-FU, fluorouracil. And again, by basically creating these false building blocks, we can kill a cancer because it utilizes these defective building blocks rather than using the molecules that are needed to divide and for the cell to live. Irinotecan is another drug like that. It's basically a drug that interferes with enzymes called topoisomerases. And basically, when DNA tries to replicate, it's all twisted up. This particular drug attacks a mechanism that allows relaxation of the DNA, and instead of the DNA relaxing, it breaks. And with broken DNA, you can't actually replicate a cell. The last are the Metonic Inhibitors. These are compounds derived from natural products, such as plants. And I gave you the example of paclitaxel from the bark of the Pacific yew tree. And for instance, paclitaxel is very interesting because it arrests cells that are trying to divide, and these cells are frozen in division and die because they can't complete the process of multiplying. So how are these agents used? Well, I'll tell you that in a moment, but I'll tell you also that the newer agents are for the most part antibodies. The drugs that are approved for esophageal and stomach cancer, the ones that aren't the chemicals that I just showed you, are basically all antibodies. And one in the left top hand corner is called ramucirumab, which basically attaches to a receptor that stimulates something called angiogenesis, and it basically prevents the formation of new blood vessels to feed oxygen to the cancer. On the right, you see a drug called Trastuzumab, which basically is a molecule that attaches to a receptor on the outside of the cell. About 1 in 5 of these esophageal and gastric cancers will have this receptor. And this receptor process is not fully understood, although the pathway is thought to improve communication within the cell and also to help with it's also a mechanism that basically helps shut down cells that are defective. And by blocking this, by overactivating this process, cells don't die. And this particular mechanism, this drug, can basically help cells that are defective die. And the most recent, on the left bottom corner, are the immunotherapies, the checkpoint inhibitors. And basically, these drugs can attach to the immune cells to activate the immune system. Many cancers basically have found a way of cloaking themselves so that they look like normal cells to our immune system. And basically, these antibodies allow us to uncloak the cancer and allow our immune system to see the cancers and attack it. So what are the best frontline options for this disease? Well, the first slide that I'd like to show you is basically just to show you where we've come from and how far we've come. Basically, back in 1985, we were still using single drugs, 5-FU, 5-fluorouracil by itself. And then we started combining drugs. We started adding different drugs together and actually found that combining chemotherapy drugs together work better than single drugs by themselves. Now, this is a big alphabet soup here, and you really don't need to focus on the individual letters. What you need to understand is that each box represents a randomized study of several hundred to 1,000 patients, where one group of patients got one drug, one group of the other patients got another drug, and there was a winner in each case. And that's how we moved from one treatment to the next treatment, and where we are now in 2019 at the bottom, where the current standards of care include regimens called FOLFOX, modified DCF, FOLFIRI, and various ECF variants. And I don't have time to go into all of these individual treatments, but suffice it to say that many patients in the current age are treated with the regimens that we see here at the bottom. Now, the one that's used most frequently in the United States is a regimen called FOLFOX. And FOLFOX now probably accounts for 2/3 of all the treatments given in the front line for patients with this disease. And this is based on a study that now is about a decade old that was conducted by large cooperative groups in the United States. These are where large centers work together to accrue patients. And although the study is a lot more complicated than I have time to tell you, it ultimately came down to a comparison of 3 regimens: the ECF regimen, the IC regimen, and the FOLFOX regimen. And the bottom line is that the FOLFOX regimen was as good as what was then the standard of care, this ECF regimen, but it had significant less side effects, and patients didn't have to lower the doses of the treatments. They didn't have to discontinue the treatments due to side effects. So not every time is the winner the treatment that has the best response or the best survival. Sometimes a regimen is a winner because it has less side effects, and that's what happened in this particular case. So that's the current standard frontline treatment for this disease. Now, another treatment called FOLFIRI, where we use irinotecan, this is that topoisomerase agent that I spoke about, seems to be another regimen that seems to be quite good. Now, I'm going to be showing a few graphs like this, and I should probably just explain this because I think a lot of people just don't have experience with these. And in the vertical axis that you see here, that's a proportional score, so 20%, 40%, 60%. And then on the horizontal line, you see months of time. And basically what this shows is an endpoint that I actually quite like, which is called time to treatment failure, because in many ways this is the most important thing. How long will a particular treatment work for a particular patient or a group of patients? And really you want the drug that people can be on for the longest period of time before it fails, either because it causes too much toxicity or the cancer grows. So in this particular case, you can see that this FOLFIRI regimen had a slight improvement over the ECX regimen because people were able to stay on it for a longer period of time. And that's really what the name of the game is. You want to have your cancer controlled for the longest period of time possible. So this is another option, for instance, if patients can't get the FOLFOX regimen. Excuse me. Now, probably one of the most important studies that we use today is a regimen or a trial called the Toga Study. So it's pretty easy to remember. Anybody who's into toga parties or whatever will remember this quite well. But the Toga Study was a study that looked at standard chemotherapy with or without an antibody called Trastuzumab. And basically, in this study, people got the standard treatment or were randomized to the addition of this particular antibody. And these were not just any patients. These patients had to have a protein on the outside of their cancer cell that was receptive to this antibody. And only about 1 in 5 patients with esophageal and GE junction cancer will have this, and only about 5% of patients with distal gastric cancer will have this. So it's a small subgroup, but it's a group that actually can do quite well with this particular treatment. What you see here is a graph that looks at response rate. And on the left is the blue one. The blue shows basically chemotherapy by itself. And then in orange, you see what the antibody adds. And you can see that the addition of the antibody significantly increased the chances of the cancer shrinking. And more importantly, on the right in the box, you can see that there was a 5.2-month improvement in survival for patients who had this antibody on their tumor cells. So this was an easy FDA approval. This drug is used now for all patients in the front line who have this antibody on their cancer cell. Now, not all trials work out like we would like them to, and I think there isn't a person in this room who hasn't heard about immunotherapy. And there's a lot of excitement with immunotherapy, and again, we and many others are trying to see what the benefits are of immunotherapy and how we can incorporate this in our current treatments. So one of these studies is called Keynote 62, in which the primary goal was to see if we added immunotherapy, a checkpoint inhibitor, to standard chemotherapy, just like it was in the Toga study, where they looked to see if you add an antibody, does it improve survival? So what do you think? Does immunotherapy improve the outcome over surgery alone? Well, this is what we call cancer control, and again, the percentage of patients with cancer control are on the vertical axis and the time in months. And you can see that unfortunately the two curves pretty much overlap except for the end. So the answer was that adding immunotherapy to frontline treatment doesn't seem to improve the percentage of patients who have control of their cancer. There may be some stragglers, some patients who do benefit, and that's why the curves do separate at the end, but that's a group that we're still investigating, and I think that the bottom line here is that the first data that we're getting back is that adding immunotherapy in the frontline setting isn't necessarily better for our patients. So what about second-line treatment? Well, really, up until about 10 years ago, we had not proven yet that second-line treatment for either esophageal or gastric cancer could actually improve the outcome for patients. It was really only this study called Cougar-2 that for the first time showed that adding additional chemotherapy after patients progressed after their first treatment could improve the outcome. In this study, they basically took patients who had already received platinum and 5-FU therapy, so something like FOLFOX or cisplatin 5-FU, and these patients were randomized either to just best supportive care, where the doctor just tries to make you feel better, or to the best supportive care plus chemotherapy. And basically what the study showed was that the chemotherapy in the second line could dramatically shrink cancers in about 7% of patients, but more importantly could prevent the cancer from growing for a period of time in about 46% of patients, and that at 6 months, a third or almost a third of the patients had control of their cancer, and it prevented the growth of their cancer. So when you compared this docetaxel treatment to best supportive care, basically the most important points to note is that in relative terms, 6-month survival was improved by 70% and overall survival was improved by 45%. And this was now the first time that we showed that additional treatment beyond the first line of therapy could be beneficial for patients and really started the modern era of multi-line therapy for our patients. Right around this time, we really saw the use of angiogenesis inhibitors developing. And basically, angiogenesis inhibitors are drugs that prevent cancer cells or cancer tumors from recruiting blood vessels to feed oxygen to them. And they basically destroy blood vessels and shut off oxygen supply to cancers and have been shown to work in a variety of cancers, including lung cancer and colon cancer, as well as some other malignancies. The same thing was tried here in stomach cancer, and as you can see here, this was a standard randomization process. Patients who had received prior therapy were randomized to either placebo or to this drug called ramucirumab, this angiogenesis inhibitor. And basically, when we look at this curve again, you can see that when these lines come down, that there was no difference between the two groups, but then we see a separation between the two curves. And what that really means is that there was a subgroup of patients that benefited from this agent and had a delay in the growth of their cancer. And in other words, basically, this treatment could delay the growth of their cancer. And for instance, duration cancer control in the table on the right was nearly doubled over basically just treating patients with best supportive care alone. Another study now tried to combine these two treatments, so combining the taxane, this drug that's derived from the Pacific yew tree, with this angiogenesis inhibitor to see if the two drugs could work better together. And again, what we see is when we look at cancer control and response rate, we see that the combination of these two drugs versus just the taxane alone delayed the time in which cancers grew. And basically that's the name of the game. We need to delay the cancer from growing. In this trial, the combination had a response rate that was almost 30%. Disease control rate was about 80% with the combination. This was a significant improvement over what we had seen before and really is now considered to be the standard second-line treatment for both esophageal and gastric adenocarcinomas. Now, what about immunotherapy? Well, immunotherapy has seen a number of studies now, and the most important one in the second line is one that was studied in esophageal cancer called Keynote 181. And basically in this study, the investigators randomized patients to either standard chemotherapy, drugs that I just talked about, docetaxel and irinotecan, or to immunotherapy, this checkpoint inhibitor called pembrolizumab. And what the study basically showed was that immunotherapy in certain subgroups of patients could be better than chemotherapy. And here you can see the response rate. You can see in the turquoise or teal that there was a higher chance of responding to immunotherapy than on the right in, I guess, brown or reddish brown on the right with a much lower response rate. So there could be higher response rates. And ultimately what they found was that the patients who had squamous cell carcinoma and those patients who had a high immune response score, and that's what we call a PD-L1 CPS score. And basically this is our ability now to handicap patients and to be able to tell people what their chances are of responding to immunotherapy. Those patients that seem to have a high score, one that suggests that they have a good chance of responding to immunotherapy, those patients did particularly well. And based on this study, the FDA has approved immunotherapy in the second line for patients who have squamous cell carcinoma with a CPS score higher than 10. And this just shows you, again, cancer control. And again, I think you can see on the left, the patients that had a CPS score of greater than 10, there's a greater separation of the curves between versus the other two groups. And that's why, again, the FDA didn't approve this drug for everybody, but just for the group that seemed to have responded best. So that moves us on now to third-line therapy. And basically, there have now been a number of studies that have looked at third-line treatment for this disease. One is called Attraction 2. And basically in this study, patients had received multiple prior lines of therapy, so multiple chemotherapies before, and were randomized to placebo or to this checkpoint inhibitor called nivolumab. And the bottom line here is that the nivolumab was able to delay the growth of the cancer in a subgroup of patients. In the graph on the right, you can see how the two curves completely overlap, and then just under 50%, you see how the two curves separate. And those are the patients that benefit from this agent. There is a delay in growth of the cancer in that group of patients. And when we quantify this, it basically shows us that at 6 months, for instance, patients on nivolumab, about 1 out of 5 patients had no growth of their cancer, whereas on placebo, virtually everybody had already had progression of their cancer. Also, if you look at nivolumab, the response rate, you can see that it was just over 11%. So 1 out of 10 patients had a dramatic response to this agent. Another important study that really has allowed us to use immunotherapy for our patients with gastric and esophageal cancer is a study called Keynote 59. And again, this was a study looking at immunotherapy in patients who had received multiple prior chemotherapies. So these patients had refractory disease. And ultimately, what the study showed was that this propensity to respond to immunotherapy is important because they were able to show that those patients who had tumors that were PD-L1 positive, those tumors that where the immune system seemed to be mounting a response to their tumors, they had a much better chance of responding than those that didn't. That's why we see that dramatic responses occurred in 15.5% of patients with PD-L1 positive tumors and only in 6.4% of patients with PD-L1 negative tumors. Dr. Jurgelin discussed microsatellite instability with you earlier, and basically these are what we call mismatch repair proteins. Patients who have a defect in this have lots of genetic abnormalities that make cancer look much different than the normal tissue. And in patients who are MSI high, where their tumors look significantly different than the normal tissues in those people, we see response rates just under 60%. So dramatic responses to these agents in the majority of patients. Whereas tumors that are not MSI high, the chances of response are much lower, 9% you can see here. One of the reasons that the FDA approved checkpoint inhibitors for esophageal and gastric cancer is that these agents, when they work, they really work. A lot of chemotherapies can work for several months, but immunotherapies, when they do work, they can work from 6 months to it hasn't come back yet. And really, those patients who respond to immunotherapy are really the lucky ones because these responses can be very durable. And one of the reasons that the FDA approved these agents was that you can see here median duration of response in PD-L1 positive patients was 16.3 months, and it's actually ongoing. We actually were the largest accruers of this study. I have several patients who remain in remission with these agents. I just wish it were more patients. Unfortunately, this is an exciting therapy for a minority of patients. In esophageal cancer, we've basically shown the same thing. This is Keynote 180, and the bottom line here is that these drugs work similarly in esophageal cancer as they do in gastric cancer. A new approval by the FDA is a drug called TAS-102. This is a modified version of 5-fluorouracil. It's too complicated to really go into the details of this, but the bottom line in this study was that it again was for patients who had multiple refractory disease. These patients had already had progression on multiple lines of chemotherapy, and the bottom line here is that once again you can see here patients with cancer control, you can see that about half of the patients didn't benefit from this therapy, and then we see a separation of the curves where we see a delay in growth of the cancer in a group of patients. And again, this delay in growth obviously is important and has led to FDA approval for this agent for this disease. So I would conclude from these results that for metastatic esophagogastric cancer, all patients should be checked for microsatellite instability, HER2/neu, and a CPS immunotherapy score up front. In the first line, FOLFOX is the current standard, and then FOLFIRI is a reasonable alternative. The old regimen called ECF, which includes epirubicin, is too toxic and adds little benefit. And Trastuzumab should be added for all patients that are HER2/neu 3+ or 2+ with FISH-positive tumors. Microsatellite high patients with CPS scores of 10 or higher should be considered for immunotherapy like pembrolizumab. In the second line, this paclitaxel and ramucirumab combination is probably the best choice for most patients with adenocarcinoma. For patients with squamous cell carcinoma and high immunotherapy scores, those patients should receive pembrolizumab. And in third line, these checkpoint inhibitors like pembrolizumab or nivolumab should be offered to all patients that are PD-L1 positive if the drugs haven't been given already. And otherwise, we see that taxanes can be helpful in squamous cell carcinoma patients, and this TAS-102 or FTD-TPI drug should be considered for adenocarcinoma patients. So I only have a few more slides about patients with more localized disease. For localized esophageal cancer, the standard of care had traditionally been surgery alone. Dr. Wee showed you earlier some results from the CROSS study, but just to show you some background here, basically there have been several dozen studies that have looked at the benefit of adding chemoradiation therapy to surgery, and basically every single study shows that there is a benefit to giving chemoradiation and not just doing surgery alone. The most important of these studies is the CROSS trial that Dr. Wee just showed you. This is basically radiation therapy and then weekly chemotherapy with paclitaxel and carboplatin. The study basically showed that if you got this regimen, there was no residual cancer after chemoradiation therapy in just under a third of the patients. The median survival was doubled with chemoradiation therapy over surgery alone, and median survival was nearly quadrupled for patients with squamous cell carcinoma, and median survival was improved by 66% in adenocarcinoma patients. So as you can imagine, this revolutionized therapy for locally advanced esophageal cancer, and since the publication in 2012, all of our patients that can tolerate this treatment have been receiving this particular therapy before their surgery. Now, as far as gastric cancer is concerned, radiation therapy has traditionally played less of a role for this disease, and the current standard of care was initiated back in 2008 when a British group published the MAGIC trial in the New England Journal of Medicine. Up until that time, the standard of care had just been surgery by itself, and in this trial, they decided to add aggressive chemotherapy both before and after the resection. What the study ultimately showed was that 2-year survival could be improved by 23% with this perioperative chemotherapy over surgery alone, and 5-year survival could be improved by 57% over perioperative chemotherapy over surgery alone. Median survival was improved by 9 months with this perioperative chemotherapy over surgery alone, and subsequently we began using this chemotherapy for all of our patients with locally advanced gastric cancer to improve the outcome. But this is not the current standard of care. The current standard of care changed in 2017 when the Germans presented their results from the FLOT4 study. And basically what they did was they took the MAGIC study that I just showed you and made that the standard arm and randomized patients with a more aggressive chemotherapy that included the taxane, that one that's derived from the Pacific yew tree. And basically they did a large randomized study, and the results have been published. And basically what we've seen now is that the 2-year survival has now been improved by another 15%. So that's, again, another 15%. And then 5-year survival has been improved by another 25%. And median survival is now a 15-month improvement over the MAGIC regimen. So from going from surgery alone to MAGIC to FLOT, we've really been able to move the goalpost for our patients. And although too many patients are still dying, we've really been able to cut this down and improve the outcome for our patients. So I would say for localized stomach cancer, postoperative 5-FU-based chemoradiation therapy remains one standard of care, but really the perioperative FLOT regimen appears to be an improvement over this MAGIC regimen and should be considered for stronger, healthier patients. So thank you very much for your attention, and I don't know if I have any time for questions. Thank you. Maybe one question or so, and then we'll move on to our next speaker. Yes?
As the checkpoint inhibitors are somewhat effective, there's a lot of people who don't do as well, and I'm reading about therapies with respect to neoantigens where they're trying to look at hotspots. Can you talk a little bit about that, and if that's relevant to the gastric cancer?
Absolutely. So, as I think I've just shown you, although these drugs work really great in some patients, unfortunately they don't seem to work great for the majority of patients. And part of what we're looking at is to see why that is. And one of the things that we believe is going on is that in some patients, the immune system is activated. So the immune system knows there's cancer, it's attacking it, and by using these agents, we can almost enhance that process. But other cancers, the immune system doesn't see it. And basically, the problem here is simply that even if we stimulate the immune system, it still doesn't see the cancer. The hotspots are really areas where the immune system is seeing the cancer. And a part of what we're trying to do now that the first wave of immunotherapy has been completed, these basic trials using single agents has been completed, the next step now is to combine these agents with other agents that can change a tumor from being what we call cold to hot. And the whole idea is basically to change everybody into a responder. And right now we really not have found really a perfect strategy for every patient. James is going to be the one, Dr. Cleary is the next speaker, and he's actually going to be the one who will tell you a little bit more about how we're trying to do this. But the idea has been really to try to figure out how to rev up the immune system to kill these cancers.
Can I ask one quick?
Of course, yeah.
I noticed in many of the clinical trial protocols you can read online are that autoimmune disease is an exclusion criteria. Could you just speak to that?
Absolutely, yeah. So this is an unfortunate side effect with immunotherapy. So most patients tolerate these treatments remarkably well, and they're, on average, far fewer side effects to immunotherapy than they are to conventional chemotherapy, because conventional chemotherapy is basically poison that just poisons the cancer cells more than they do the patient. But immunotherapy, it just revs up the immune system. The problem is that in a small percentage of patients, it revs up the immune system so much that the immune system attacks the body. And we have seen this happen with almost every organ that you can imagine. I've seen pneumonitis, nephritis, colitis, cerebellitis. I've seen even inflammation in the eye where the immune system attacks the eye. And literally, the immune system could turn on anything. Now, if you already have an autoimmune disease, that actually will get ramped up. And that's why we've generally excluded patients who already have a disease where the immune system is attacking their body, where we actually have to give steroids to cool off the immune system. We're beginning to learn that in some cases it might be okay and safer, but also, for instance, anybody who's had a transplant, a transplant, not an autologous transplant, but a transplant from somebody else where we actually suppress the immune system, you cannot give them immunotherapy because it rejects the transplant. So these are things that we're beginning to learn. And again, that point about hotspots, we are trying to create hotspots in our patients so that the treatments work. I don't know how much time we have, because maybe it would be good just to write things down. I'm sorry. We are that